a americana doutora Anne Gilroy. Publicada no Brasil pela editora Guanabara Kogan, integrante do Grupo GEM, Grupo Editorial Nacional. A obra é voltada para estudantes da área da saúde e integra também bibliografia de curso de Ciências Biológicas da Anhanguera Educacional. Sobre o Grupo GEM, que é a Grupo Editora Nacional, que traz, em parceria com a universidade, a nossa ilustre palestrante, tem a plataforma de algumas das mais prestigiosas editoras das áreas de saúde, área jurídica, ciências exatas, humanas e sociais aplicadas. A GEM reúne em um catálogo de mais de 3.500 obras, das quais mais de 700 títulos estão disponíveis também em versão digital ou como aplicativos. Além de prover conteúdos para a formação de graduação e aperfeiçoamento profissional, o Grupo Editorial Nacional conta com unidades de negócios especializadas na prestação de serviços a indústrias farmacêuticas e ensino presencial e à distância. Além disso, a GEM conta com um catálogo de obras em língua espanhola, distribuídas em 15 países. O grupo exporta suas publicações para os países da língua portuguesa por meio de sua coligada Guanabara, sediada em Portugal. Queremos agradecer a Andréia, que representa aqui o Grupo GEM, e que muito gentilmente está conosco nesta tarde com a nossa ilustre convidada palestrante. Representando a reitoria da Universidade Anhanguera Uniderp, para recepcionar a todos, convidamos a professora doutora Luciana Paz de Andrade, nossa pró-reitora de pesquisa e pós-graduação e coordenadora do curso de Ciências Biológicas.
Boa tarde, pessoal. Mais uma vez, reiterando os agradecimentos do Oscar. Eu gostaria de agradecer muito a presença de todos. Dizer que é um prazer e uma satisfação muito grande participar desse evento hoje, recebendo aqui na nossa casa, na nossa universidade, pessoa tão ilustre e importante quanto a nossa palestrante de hoje. Aproveitando a oportunidade, em conversa com a nossa autora e palestrante, a gente gostaria de dizer que o foco principal da palestra vai ser a respeito do tema que está aqui, né? Ensinando anatomia, as questões do passado, do presente e um pouquinho do nosso futuro, não? Esse é o tema que a palestrante vai tratar, né? Ela vem da Universidade de Massachusetts, uma conceituadíssima universidade no mundo todo, né? Todos já ouviram falar da universidade. Então, é muito especial a gente saber que nós utilizamos na universidade um livro que tem como autora uma pessoa que vem de uma universidade tão importante, de tanto renome. Todos vocês devem conhecer o Atlas de Anatomia, que aqui está com a capa do PLT, do nosso programa de livro-texto, mas que tem como capa original, já vou mostrar para vocês a capa, que fica aqui no verso, né, do livro, do PLT, mas que está aqui. A doutora fez questão, e a editora fez questão de nos trazer esses 2 exemplares com a capa original, que vocês também conhecem. Então, é muito interessante, é um momento, eu acho que, único, da gente poder participar de uma palestra, na qual nós utilizamos o livro o tempo todo para estudar, e aqui nós temos representantes de vários cursos da universidade, medicina, enfermagem, nutrição, biologia, fisioterapia, vamos lá, lembrando quem eu não falei, psicologia, farmácia, educação física, né? Todos esses cursos têm aula de anatomia humana, todos esses cursos precisam estudar, todos vocês, todos os professores, enfim. É oportunidade única, incrível, imperdível. Então, por isso, mais uma vez, agradeço a presença de todos vocês e, mais ainda, da nossa ilustre palestrante. Seja muito bem-vinda e que tenhamos, então, uma ótima palestra, professora. Muito obrigada.
Professora Luciana, vamos passar alguns informes. Os senhores participantes têm de assinar a lista de presença, colocando o seu nome de forma correta, como nós estamos pedindo, por favor, para que possamos emitir o certificado. E deverão retirar na coordenação dos cursos, ok? Um certificado de participação. Ao final da palestra, nós teremos aqui 20 minutos de perguntas com a nossa palestrante convidada, para que vocês possam fazer a intervenção, e faremos o sorteio de 2 exemplares que a doutora vai fazer, vai autografar para aqueles que forem privilegiados do sorteio do livro, ok? Ao saírem, com calma, vamos fazer a devolução do nosso aparelho de tradução, para que vocês possam pegar os documentos de vocês, ok? Nos permita fazer uma breve apresentação do seu currículo, doutora Anne. Diretora de Imagem e Recursos de Anatomia no Centro Interprofissional para Aprendizagem Experiencial e Simulação da Universidade de Massachusetts, nos Estados Unidos. Além disso, é palestrante do programa e apresenta a relevância internacional pelo desenvolvimento de um programa longitudinal e abrangente na anatomia clínica, com a criação de projetos de revisão de anatomia inovadores, que combinam aulas de anatomia clínica e dissecação de cadáveres, com procedimentos cirúrgicos simulados. A anatomia humana apresenta variações entre indivíduos, segundo as idades, raças, sexo e biotipo. É um vasto universo a ser descoberto. Podemos esquecer o nome de cada músculo ou região óssea, mas não devemos esquecer a realidade física do corpo inerte ou em movimento para representá-lo artisticamente. É essa palestra que nos traz nesta tarde, doutora Anne Gilroy. Please welcome.
Thank you very much. Thank you all for being here. I am delighted to be here finally. It's been a very adventurous day so far, but I do want to thank the Anhengwara group, as well as my sponsor, Grupo Gen, in particular, Andrea Xavier, who got me here safely. So before I start, I just wanted to ask, you are all have taken anatomy? Yes? Yes? How many of you are taking anatomy right now? Oh, okay. Okay. All right. And so, do you like it? Yes. Do you like it? Okay. Okay. Yes. Well, I love anatomy, and for me, it's very exciting to be part of the education in anatomy at this time. It's a very exciting time because we have lots of changes happening, and I think in the future we're going to have even more exciting things happen. And I'm going to talk about the future, in a little bit, but I want to start talking first a little bit about the history of teaching anatomy, because I think in order to appreciate where we are right now with our education, we need to see how far we have come, all right? So, yes, so I don't have a clicker. Okay. This is a clicker. Yes. Excellent. Can we dim the lights? Just a little bit. Okay, sorry. So, historically, say the late 1800s, the medical schools that existed in North America and Canada were proprietary. So they were for profit, all right? They were not very well organized. They trained very poor physicians. The curriculum wasn't very organized. But in fact, most of the curriculum actually was anatomy. And that's because at that time, all of the other biological sciences really had not advanced very far. Okay, whoops, excuse me. So the anatomy courses at that time were about 1,000 hours. Yes. So how many hours is your anatomy class over this semester? A few hundred, perhaps? Maybe 100, 200, okay? So imagine a course that runs 1,000 hours, but you didn't have biochemistry, you didn't have genetics, you didn't have cell biology. So anatomy took up the entire curriculum, all right? There were some things that were changing, but it was very slow. But in 1910, a man named Abraham Flexner wrote a critique of medical education in medical schools in North America and Canada. And this report, known as the Flexner report, are you familiar with that? Have you heard of that? No, okay. Well, this report was the single most important event in the history of medical education, even up until now, probably, because many of the things that were changed by that report determined how we teach basic science, the entire medical curriculum, even today, all right? There were many points that this Abraham Flexner made, but one of the main things was that he felt that the medical schools that had existed prior to this, they were not training good physicians because the training was not based in scientific reasoning. He felt that any training for physicians should be based in, they should be engaged in scientific exploration, and the faculty really should be doing research. The medical schools should be associated with academically oriented hospitals, and that would allow the physicians, who were the teachers, to actually stimulate the students to do research. And the research would come from questions that came up when the physicians were actually dealing with patients. So it was very closely tied to what they were teaching. And he felt this would improve both teaching and also patient care. The other thing that, and he said, as I said, he said many things in this report, but the other thing that was very important was that he envisioned a medical curriculum where the clinical phase of instruction, that is where they actually learned in the clinics, that was actually part then of the medical school instead of the hospital. Now, if you think about it, that actually portended the way medical education has been running for the last 100 years. This report changed several things. We now have, before, medical schools didn't have any admission standards. Anybody could get into medical school. Now, of course, we have very strict standards for entrance, all right? We also have medical schools almost always associated with some academic center that does research. In fact, at least in North America, the research component of medical schools almost always outweighs the educational effort. And of course, the education in medical school for the last 100 years has been structured so that year 1 and 2, you learn the basic sciences. Year 3, 4, and if there's a 5th year, those are the years you learn clinical medicine, right? All that started with the Flexner report. So things did change, but something that didn't change very soon was the fact that courses, even in 1930, still ran an average of 800 hours, okay? But one of the things that was stimulated by this report was faculty started doing more research. And more research meant that those sciences that previously had not been well developed now came into prominence. And so gradually, as they became more important in medical education. And so they took up time in the curriculum. And so gradually the anatomy courses reduced. So they reduced in number from 800 in 1930 or so till in 1990, there was about in that period, there was about a 55% decrease in the number of hours of the course, all right? So the average course in 1990 still was somewhere around 350 hours. Still a very long course, all right? But even though there was that change, most of anatomy education did not change. So it was still, oh, sorry. Apologize. It was still taught by very traditionally trained anatomists, all right, not by clinicians. They taught in such a way that, similar to what I'm doing right now, it was very lecture-based, one-way conversation. Students sat there passively learning, all right? Anatomy, like all of the subjects, were taught separately. So you had an anatomy course, you had a separate physiology course, a separate biochemistry course. There was no integration in the courses. And most importantly for anatomy, there was no clinical relevance. These traditional anatomists were not clinicians, and so they really didn't have the clinical experience to bring to the course. They didn't understand the role of anatomy in medicine well enough to explain it to students. And at that time, clinicians were not invited into the classroom. They stayed in the hospital and the clinics, and the anatomists taught in the first 2 years all the basic sciences with their colleagues, and the clinicians took the students in the 3rd and 4th years, all right? So that lasted all the way through into the 90s. Now, one of the things that happened in the 90s was that these other biological sciences had reached a level of sophistication where it really influenced patient care. Patients were being better cared for because we knew more, all right? But because of that, medical education began to focus on patient care, not just education. And it was, there were many complaints that what was being learned in the research labs was not being conveyed in the medical school. There was a very big gap. And so those traditional, those conventional teaching practices came under a lot of scrutiny. And as a result, there were the beginnings of curricular changes. So in 1990 and in the 90s, we saw medical schools start to change their curriculum. And that changed how we teach anatomy and everything else, okay? One of the main emphases became core competencies. Do you have core competencies? Do you deal with competencies here? Yes? Okay. So in 1999, the main governing body, which is the Accreditation Council for Graduate Medical Education, and the American Board of Medical Specialties, these two oversee the training of our residents and also their certification, all right, and their recertification. They designed and adopted 6 core competencies, all right, and they applied it to 24 medical specialty residency programs, all right? And then 8 years later, in 2007, that was extended to cover all residency programs in North America, right? That means that now there is a national mandate. It is required of all residents in every medical specialty that they undergo training and evaluation in these 6 areas. which I will mention in a few minutes, okay? Now, along at this same time, residency directors were complaining to medical school course directors and deans that the graduating medical students were not adequately trained for a residency program. So that when they came into the residency program, they didn't have enough of the correct information. So that was a big problem, obviously. And so as a result of that, this organization here, these two organizations here, the association, oh, sorry. Yes, this is hard to use, I apologize. Well, I'll just point. So the Association of American Medical Colleges and the Howard Hughes Medical Institute, they formed a committee. And that committee put out a report that advocated that undergraduate medical students be taught in a competency-based curriculum, all right? So in other words, that the whole curriculum would have to change, and it would be based on the competencies that were designed by the ACGME, all right? So what were these competencies? Well, there were 6. I have listed 8 here because in the time since the initial adaptation, 2 more have been added. So these 6, patient care, all right? Well, patient care suggests that these physicians have to provide care that is compassionate, appropriate, and effective, both for health problems, but also for promoting health, okay? They had to demonstrate a certain level of proficiency in medical knowledge in terms of things that were known, but also in terms of things that were evolving in the areas of biomedical, clinical, and even the cognitive sciences, and how those were adapted in the practice of medicine. They also were charged with being able to understand how to investigate their own practices. How well were they doing? They had to evaluate that. They also had to assimilate new information and enroll that into their practices. So in other words, they had to be constantly evaluating their own performances and improving it. They had to demonstrate communication skills in which they could transfer information not just to a patient and their family, but also to colleagues, to other professionals. They had to be aware of the rest of the healthcare system. They had to be able to engage colleagues for particular medical problems. So for example, they may need to be the primary care person who manages the care of a patient that involves many other medical specialties, okay? So they had to understand the medical system. And finally, they had to exhibit qualities of professionalism that of course included, a commitment to the practice of medicine, but also they had to demonstrate certain ethical standards. They had to be sensitive to various patient populations, particularly those that were most vulnerable. Now, these last 2, as I said, were added later because they felt that the original 6 didn't adequately cover them. The first is interprofessional collaborative practice. And what that means is these residents, upon graduation from their program, had to be able to work with not just other physicians in different specialties, but other healthcare workers outside of their own career choice. So in other words, they had to be able to work with nurses, pharmacists, pathologists, all right? So, and more, when we engage in things like global medicine, whole teams of physicians go someplace, but they carry with them other professionals, nurses and the pharmacists and dentists. And so they had to be able to work with all of them. And then the last one personal and professional development, that sort of sounds like they have to take time to go skiing or something, and that's not the case. What that refers to is they had to understand their own limitations. They had to demonstrate an ability to manage the stress that their profession was going to foist on them. They had to have a certain level of confidence, trustworthiness. So it's sort of a personal development thing. So these are the competencies that our curricula are now based on, all right? So what does that kind of curriculum look like? Well, you know, these competencies really, if you look at them, what they do is they focus on not just the patient, but on patient and all of society. They focus on acquiring and getting proficient at skills, not just acquiring knowledge, all right? So collecting facts, which is what always used to be the goal, is no longer the only goal. Now they have to actually collect experiences in clinical skills, and they have to reach a certain proficiency level. They are evaluated by how well they do, by their performance, and by the outcome of their practices. And these curricula really depend on disciplines being meshed together, all right? So anatomy, physiology, histology, all of those need to be taught together, all right, not as separate subjects. And they have to have experiences that allow them to be able to talk to and work with other professionals. It's been demonstrated and is well accepted that each professional does a much better job if they are working in collaboration with other professionals, as opposed to each of them coming at this separately, all right? So this was all part of it. Now, these curricula have really challenged a lot of our traditional teaching strategies. And I can tell you that having been through a transition to a different kind of curricula, it's very difficult for faculty to make this transition because the strategies we used to use to teach students don't work the way we thought they were working, okay? It is very well known that the way people learn best is not the way we teach medicine. And so this competency-based curriculum does address that. And so we have changed a lot of the strategies. The first one here is to reduce the one-way conversation. Now, obviously, sometimes that's a good thing, because if you were all talking at the same time I'm talking, it wouldn't work. So sometimes it's okay to do this. But for a curriculum, you know, we mostly give PowerPoints like this, all right? PowerPoint was rolled out by Microsoft in 1990. And when it came out, well, first of all, in 1990, most of us didn't own a computer, if you can even imagine not owning a computer. But we didn't. It was really the late 90s when everybody owned a computer, everybody started really teaching with PowerPoints, all right? And it was hailed as the most amazing thing, the most amazing aid, and it really did make lectures much more interesting because there was more visual, all right? But if you talk to communication experts, what they tell us is that we have become far too dependent on PowerPoints. It's a crutch, it's not an aid. Microsoft came out with statistics in 2012 that if you put all the versions of PowerPoint together, 95% of all presentations use PowerPoint, okay? They own 95% of the market share, right? That's a little scary, isn't it? And so what it does, though, is it promotes this one-way conversation where students sit there passively to learn, and they just absorb. There's no interaction. And so we are now moving away from that. We will still use it, but we will put it into perspective. And so what we emphasize now in teaching is experiences where the students, can sort of immerse themselves in it. They participate in an event. It's experiential. It's interactive. Okay? Because we know that people learn best if they actually get to learn it and practice it and be assessed in it in the context in which they will use it. So that's the goal, right? We encourage collaborative learning. We do that by encouraging peer teaching or study groups, or even assigning problems where the group works together, all right? So there are ways to do that. We also cater to the adult population. Adults generally learn a subject because they need that useful information to accomplish a task or meet a certain goal. They don't, I assume you don't either, learn anatomy simply because you love anatomy, right? I would do that, but most students don't need to do that. You learn anatomy because you're going to use anatomy, all right? And that's the way adults learn, and so that's the way they should be taught, all right? So we no longer require, at least a lot of schools, no longer require students to spend hours memorizing little facts, okay? We focus much more on the application of that material. What are you going to do with that? Why is it important? And our students, and hopefully you as well, ask, well, usually it's in the form of, why do I need to learn this? But what you're saying is, tell me why that's important. Don't just tell me I need to memorize it, right? And so education is moving in that direction, okay? So it's moving to a learner-centered versus a teacher-centered curriculum. More and more of the responsibility for this whole educational process sits on the shoulders of the students instead of the faculty, all right? Now, when we started transitioning to this kind of curriculum, and I say we, meaning at UMass, University of Massachusetts, but in speaking with colleagues from other schools, I know that most of them felt this way. We didn't so much say it out loud, but when you look at a curriculum like this, you really are moving away from a teacher spewing out information, okay? Being the one standing on the stage telling students. There's a certain power in that, okay? And we as teachers are used to that. And we're seeing that being threatened by this curriculum. And our roles as teachers became very questionable. So if I'm not lecturing to students and they're sort of learning on their own, what do I do? What is my role as a teacher? And that is why so many faculty, particularly older faculty, resisted these changes. But the truth is, the role has changed, but we still have a very important job to do. As teachers, we do teach them facts. We still give lectures. Maybe they're fewer and we don't include as much information, but we still teach facts. But we also teach students how to learn on their own, how to locate information from other sources, how to collect the right material, how to interpret what they collect, and how to evaluate how useful it is, and then how to apply it to your particular needs, okay? So really, our primary roles, we as teachers, we orchestrate this whole process. We guide students through this learning thing. We set the boundaries for what's important to learn. We provide, or at least lead them to, the resources where they can do this. And then we step back and we provide that very flexible learning environment where they can do it, all right? So these are difficult things to do as a teacher, but they are very important. So lots of concepts here, lots of theories. How do we actually do that when it comes down to the nitty-gritty of teaching a course, right? Well, every school does it differently, and that's because every school has different resources to draw from, they have different attitudes, they have different faculty with different talents. And so when I talk with my colleagues at conferences, I get lots of ideas, but many of those ideas I can't apply at my school because everybody has a different environment where they're trying to do this. So there are some things here that we do. There are some things that that are done at other schools, but generally these are things that we include. So we have increased the clinical content, and that's actually been decades now. At UMass, we've been doing that since I started there, and I just had my 25-year anniversary at UMass, so that was 2 weeks ago. So we've been doing that for a long time, but many schools had not. So we're now inviting clinicians into the classroom. They're in the labs. They are directing parts of the course. They have a very firm place. Okay. We talk about integrated curriculum, and that's a buzzword. Do you have an integrated curriculum here? Probably not so much. So integrated, we are required now nationally to have integrated curricula. And what that means is we take our basic sciences and we form a meshwork of information. We talk about a particular organ, we talk about the gross anatomy and also the histology of it, and then we also talk about how it works. So we integrate the disciplines, all right? And that's very common in most of the schools. The dissection lab, being anatomists, we have a dissection lab that is an incredible opportunity for us to teach clinical skills. Now, I don't know any schools that actually teach students how to do those procedures, how to intubate or anything like that. But we show them what those procedures are while they're dissecting their cadavers, and so they get a real sense for how important that anatomy is, the things that they would need to learn in order to accomplish this, so they really get a good sense for the clinical skills that they will be learning in the following years. Imaging is the tool of medicine. It is very important now. It's going to be far more important in the future, and I think it should be considered one of the basic sciences for medical students. Every clinician uses some form of radiology. So that should be taught very early in the curriculum, and there is no better subject to correlate with it than anatomy, right? It is anatomy, just looking at it in black and white, right? So very important. As I said before, we're getting away from that concept where students have to memorize lots and lots of detail. Now we encourage them to engage more in critical thinking and problem solving, as well as learning facts, of course, And we do this, by promoting sort of interactive small group learning where they can problem solve together. They can work as a group. So all of these things that I've talked about really came about because there was that increase in research, increased interest in improving patient care, stimulated all of this stuff. But the one thing that I think has had a much bigger effect on education is technology. I don't think I could get anybody to disagree with me that technology in the last 20 years, well, for some of you who are only aware of it for 5 or 10 years, but it is a virtual revolution, explosion of technology. And it has changed certainly everything about our lives, but it has definitely changed the way we do medicine, and it has changed the way we teach. Studying anatomy now, we use just about every form. This is very difficult to use, I don't want to. So we have apps. You have smartphones, they have apps. You have apps on your iPad. We have 3D reconstruction and imaging. We have high definition videography. In the operating room and in the lab, we have high fidelity simulation. All of these things have come about in the last few years, all right? So you can only imagine what 5 years from now will be like, what 10 years from now is going to be like. This is the future of everything, but certainly of medicine and therefore of medical education. One of the main things it has done is change what we teach, the content of our courses. And it's done that directly, but it's also done it very indirectly. Technology has increased the productivity of research so that we have far more knowledge than has ever existed before, right? We know far more now than they did 20 years ago, than they did 100 years ago, simply because technology has allowed us to do research that could not have been done before. All of that knowledge is available to a physician in training, right? But the knowledge is far more than you can learn in medical school, all right? But you don't have to learn it, and that's how technology has changed that. Now, every little fact is available on your handheld device, right? You can look up anything 24 hours a day. Now, that doesn't mean you don't need to have a very solid base of information, but it does mean you don't have to have every single detail at your immediate recall, all right? So we don't have to teach that way. We can spend more time on problem solving, on teaching students how to think about things, how to diagnose and how to link that with the appropriate treatments. Certainly, you know, the educational faculty have struggled with this as well because, and I can say only personally, it's hard for me to give a lecture and leave out information that I used to include because I think everything is important. But I'm an anatomist, of course, and so, but I know that there are things that students don't need to hear from me. They can learn on their own. And so this has been, you know, sort of a struggle for a lot of faculty. But I think this transition to letting students find those facts later, I think is part of what we talk about teaching skills for lifelong learning. We teach them how to find that information on their own because that's the way they're going to do it later. You know, you can't teach a subject and then stop learning it if you have a career like medicine. You need to keep learning as that field keeps growing. And so I think by teaching them how to do that early in their education is very important. So one of the problems that's resulted, and there are a lot of problems with these new curricula, one of the problems is that it sort of puts textbooks and print material on the back shelf, okay? Publishing companies don't like to hear that, and that's been a struggle and will be a struggle. But they've been very adaptive for that, to that. Most of the important publishing companies now create learning platforms. And these learning platforms really have influenced the way we teach because they allow faculty to customize a course, customize them for the particular student group they're involved with, to the level of understanding they want their students to achieve, maybe to one specialty versus another, okay? So they can bring in online resources into this. They can have links to external sources that are outside the course content, but that perhaps a student would need. Different levels, or I should say, students of different abilities will need different resources. If you are a very, very bright student and the course is not difficult for you, you may link to an external resource that gives you more information just because you're interested. On the other hand, maybe this is a subject that you're not doing well in and you need extra help. And so you can link to resources that give you review material or additional images or definitions that you don't find. Okay? So it allows students to sort of pace themselves. They can direct their own learning by their own needs. And that's what we mean by self-paced and self-directed learning. But one of the most important things that these learning platforms do is they provide self-assessments. And we know that this is one of the best ways to learn, is to test yourself constantly. And most schools now do that. Self-assessments are on these online platforms where students can take a quiz. The instructor, it may be part of the course where that grade is counted, but many times it's not. It's just a self-assessment, but the feedback is immediate. You immediately know if you got that wrong. And now you can go back and review that. And your study, you can direct your own study according to those things that you are not understanding very well. Okay? We're caught up? So from here, I thought it would be useful, maybe fun, for me to talk about the programs we have at UMass, where I am, University of Massachusetts, all right? And I do this with the introduction that we have been revising our curriculum over the last 5 years. We have done some things very well. We have done other things not well at all. So I think it puts UMass kind of in the middle. We are sort of average in terms of this innovations of curriculum, all right? And so there are schools, as I said before, that do things very differently, but most schools have had successes and failures in revising their curriculum, all right? So this will give you some of the ideas that we're involved in. So I'm going to talk about the first year. I'll start at least with the first year course, which is called the Foundations of Medicine 1. The second year courses are Foundations of Medicine 2, all right? Now, the Foundations of Medicine 1 includes several courses, all right? But I'm only going to talk about the course that involves anatomy. And that is called Development, Structure, and Function, also known as DSF, all right? So the DSF course involves anatomy and embryology, physiology, histology, and radiology, all right? And it is run by a team of 4 co-directors, all right? I direct the anatomy and embryology one. So at UMass, we have, my student class is 125 students. Is that a lot? Do you think that's a lot? Mm-hmm. Well, it actually isn't a lot because most medical schools have far more than that, but some have fewer. So again, maybe we're average, but 125 students. The DSF course starts in October and runs through the end of February, all right? In fact, I'm missing the first week of it next week, okay? So it starts next week. Before that, the students actually start early in August. But they take a course that we call Building Working Cells and Tissues. It's cell biology, biochemistry, genetics, all right? They finish that this week, and then they start the DSF course and go through February on that, all right? In that DSF course, that runs about little over 300 hours total. Seems like a lot, but remember, it's 4 different major subjects, all right? Of those 300 plus, 55 hours are anatomy lectures. That's not a lot, okay? As you can see, students are required to have laptops, and the laptops are hooked up to our learning platform, which is the Blackboard, and on that platform, they can get access to any kind of announcements or assignments. All of the lectures are videotaped and they are streamed live. and they can be accessed through that. So students can, yes, they can stay home in their pajamas and listen to the lectures. Mostly they don't do that in anatomy, but I think that's because they have to go to lab afterwards. But ours is an integrated course, so we try hard to integrate those subjects. It has been a struggle, I will be honest. It has been a little bit of a struggle, but we are getting there. The course is taught in 4 blocks, and the blocks are by region. So we start with thorax, then abdomen and pelvis, then head and neck, and then the limbs, all right? Within each one of those blocks, physiology and histology teach by system. Okay, so they'll do cardiovascular and then respiratory in that thorax block. Right? The entire course is very clinically based. We have just the anatomy lectures alone. At least a third of them are given by clinicians on clinical topics. Clinicians, one of the course directors is a clinician. Just one? Yes, just one of the course directors is a clinician, but clinicians are directors for segments of the blocks. They help us write the curriculum. They help us write exam questions. So they're very involved. They're present in the lecture. They're present in the lab. We give lectures still, but they are fewer now. They're also shorter than they used to be. So students are a little bit more responsible for covering the material. Just because we don't lecture on it doesn't mean they don't have to know it. That's a hard concept for the students to learn, but after the first exam, they do learn that. Assessments, we give quizzes every week, and they are cumulative, but they don't count for much. They just are really something for students to help pace them and keep them up to. We do have a major exam at the end of each block, and those exams are integrated with all 4 of those topics. Right? As I said, radiology is a very big part of the course. We cover all aspects of radiology. We use it for basic anatomy, just plain film. We do CTs, MRIs, ultrasound, which is really the imaging of the future because it's non-invasive, it's inexpensive, it's readily available. It is what physicians are using more and more. Unfortunately, the ultrasound machines are very expensive, and so it's difficult to train students. It's unlike these other imaging techniques. Ultrasound really needs to be taught live because it's a dynamic thing, and so it's hard to give a lecture on ultrasound. But we are trying to step up and meet that challenge. Some of the faculty even deal with arthroscopy and endoscopy, all right? But we don't require that of the students, but they get exposure to it, okay? So we have a full dissection program, and fortunately, in this revision of our curriculum, the dissection has been very well supported by our administration. We have dissection lab about 80 hours. So we only have 55 lecture hours, but we have 80 hours in the lab. So students spend a great deal of time in the lab. Many times they spend much more than that. So you have a dissection lab. Your anatomy course has a dissection lab? Yes? Okay. So our dissection, I have to wait for that. Our dissection, full cadaver dissection, all right? So we do head to toe. Our students are separated into groups of 4 or 5 at each table. All of the students dissect at the same time. Now, many schools do this differently because they have more students than can fit in the lab at once. And so they have groups that rotate, and then others rotate through that, and so they don't all dissect at once. But ours all dissect together. We have only 3 full-time anatomy faculty, And so we are the ones who give the lectures, you know, the basic lectures. We also are the ones who run the labs. But we have lots of help. We have our clinical faculty. We also have our fourth-year students. So these are our graduating medical students who want some experience back in the anatomy lab. Some of them are doing anatomy electives. Some of them are teaching assistants. I'll talk about that again. In the lab, as I said before, it's a great opportunity to expose students to some of the clinical skills, the procedures that they will be learning later. So we do that in small groups, take students out, and we have clinicians come in and do that. We do have practical exams, but the practical exams include not just anatomy, but also histology and also radiology. All right, so that's an entire thing. So here's our lab. We actually have 3 anatomy labs that are joined. All right, they are all same size. All of them have 9 tables. I'm not sure why one of the tables is missing there, but they all have 9 tables. So we have 27 tables. The anatomy labs were completely renovated about 6 years ago, I will say, about 5 or 6 years ago. So all new lighting, all new floors, new equipment. They are much nicer now than they were. One of the things that we installed with the new labs were computer stations at every table. So students have a computer that they work off of on that. On these computer stations, we have, it's not open to the internet, but what we have installed on these computers is the dissector. We use the TEMA dissector, which is their manual. We have the Atlas of Anatomy, the TEMA Atlas of Anatomy, the winking skull. And we also load the computer with CT scans of their own cadaver. So during the summer, our radiology department gets CT scans of all of the cadavers. And then those scans are read by radiology residents and faculty. And the scan for each cadaver is loaded onto the corresponding computer. So while the students are dissecting, they can actually look at the CT scans of their patient or of their cadaver and see what this structure looks like on a CT scan. All right? In addition to that, we have at several times throughout the course, the radiology residents and faculty come down into the lab and work with the students, talking to them about any pathology they might have found on that cadaver. Anything that's really interesting is sort of brought to attention of the whole course, of the whole group, okay? But it's been really useful for the students. They really get a good sense of what CT scans show and don't show, and also that correlation with anatomy. As I said, we have clinicians who come to the lab. UMass is a medical school that is physically connected to the hospital. It's the same building. And so the clinicians who work in the hospital do so because they are interested in teaching. And so we never have any problem getting clinicians to come and help us teach, especially in the anatomy lab. So we have the radiologists, of course. They're part of our course. But we have cardiologists. We have geriatricians. The aging population has really brought this into our course. So we have geriatricians who come into the lab and talk about the fact that the cadaver these students are working with, they're all very old. And that's because most of the people who die are old, right? But the students need to understand that a lot of what they're seeing is a result of age, not disease, but age, and that if they were dissecting someone who was 50 years younger, the anatomy would look somewhat different, okay? So they come into the lab, and we have pathologists. Certainly the surgeons are there, mostly the residents. One of the orthopedists actually is a co-director of the limbs musculoskeletal unit. And we have urogynecologists and anesthesiologists and internists. They are some of the people who help us do those clinical skills sessions. As I mentioned, we also have fourth-year students. Now, one of the things that many medical schools do, and we did starting back in 1990, was develop anatomy programs for all of the medical students. So at every level, students had the opportunity to come back and learn or relearn anatomy, and what they learned was based on what else they were learning at that time. So if they were in courses in pathology, we talked more about the anatomy of the pathology, and then it got more related to whatever specialty they were interested in. So there are two ways for students in the 4th year to do this. You have a 4-year program here? Students graduate after 4 years? Or 5 years? Oh, 3? Okay. Oh, okay. Okay, so our students graduate after the 4th year. So these are students who are graduating students. So there's a course that I run in March each year. It's a 4-week program. It's a very small group of students, and this is an elective. They don't have to take this. But it's a program that allows them to look at the anatomy of whatever specialty they have decided to pursue as a career. And so it's very clinically focused. They have a clinical mentor, but they also do cadaver dissection. And then there is another elective that students can do, and this is much more flexible. It's 2 weeks. They can do any 2 week of the entire year. Most of them do it during that October through February period when we're teaching that DSF course. This elective requires that they assist teaching in the lab. So that was one way for us to get help teaching in the lab. But they also take on small projects. They might make pro sections, or they might create some kinds of learning resources for us. But it's just a 2-week elective, but it's enough for them to get back into the lab, review their anatomy in whatever specialty they want. We also still teach residents. I have several residency programs where I teach them year-round, small periods of time. Here we have anesthesiologist residents in the lab. They're working on a cadaver. Those are OBGYN residents. They are learning laparoscopic techniques on a cadaver. So they use either unembalmed bodies or lightly embalmed bodies, so the tissue looks very live. So we still have that longitudinal program, although it's a little bit at risk because of these curricular changes. So the last thing I want to talk about is simulation. This is a field that is also growing enormously. I understand you have a simulation center here. I haven't seen it. I think I'm going to see it later. One of the challenges in training medical students, in training residents, is that it's very hard, perhaps it's not even ethical, to have untrained students, residents, working on live patients. I know personally when I go to the hospital, I request that I don't have medical students working on me. I believe in medical students, but not when it comes to my own safety. But this is a problem. How do residents become proficient at something if they don't practice it, all right? Well, simulation has solved that problem to a very large degree, right? This is our simulation center. Its name is iCELS, and that stands for Interprofessional Center for Experiential Learning and Simulation. All right? This is a brand new center. It opened a year ago. We built a very large 8-story building. The simulation center occupies 2 whole floors of it, 24,000 square feet. We are gradually integrating it into all of the years of the medical school. It's used by residents for training. It's used by physicians who want to keep up the level of their skills or learn new skills. It's used for continuing education programs, and it also is used for clinical research. So everybody gets to use this. In this center, we have 20 rooms for patients. Now, these are not real patients, but they are rooms where students can interview fake patients, standardized patients, all right? Do physical exams or do interviews. We also have 4 large simulation rooms or scenario rooms where we can mimic any kind of clinical situation or emergency situation so that students together can work on a scenario. We have a clinical skills lab where they can learn some of their clinical skills. We have a technical skills lab where they can learn things like suturing, for example, on wet specimens. We have high fidelity simulators, task trainers, all of that. Okay. So here are some students. These are first year students. They're listening to heart sounds on this mannequin. This is one of our physicians. She happens to be the Dean of Medical Education as well. And of course, the mannequin can simulate heartbeats under many different conditions. And so the students are learning what those heartbeats, how to correlate that with different pathologies. But they also, second, third, and sometimes even fourth year students can learn some of the clinical skills. So here they're learning chest compressions. Here they're learning how to put in a central line, but they're using ultrasound to guide them in doing that. So they're putting together a clinical skill with something they have learned previously, how to read ultrasounds, for example. And this is one of our standardized patients. Remember, I talked about the competencies, and one of them was communication skills. That's kind of hard to evaluate how well a student does that. But students spend a great deal of time with these standardized patients. Do you have standardized patients here? Do you know what I mean? Standardized patients, we have a group of over 100. These are people who get paid, but they pretend to be a patient. So they will come in, and the faculty person will say, we're studying cardiovascular today, and they say to the standardized patient, I want you to pretend to be having a heart attack. And so the patient will do that, and the students have to interview them appropriately and then diagnose it and then suggest treatment based on what the standardized patient is exhibiting. So these standardized patients are very well instructed on symptoms of a whole variety of diseases, all right? And we have a group of over 100 of them who do this with the students all the time. Okay. So here's the last thing I wanted to mention. You don't have one of these, right? You don't have an anatomage table? All right, so this is the most exciting thing I've done probably my whole 25 years. So this is a virtual anatomy simulator. It is a table. This is life size. So this is an image of a real patient, life size. So when I'm standing at this table, this is about 6 feet long, and this patient comes up. Now, this particular image, can we turn the lights down a little bit? No? So this simulator takes CT scans of patients, and it converts it. You know CT scans. Do you know CT scans? Yes? Okay. So CT scans are all cross sections, right? But this table takes those scans and reconfigures that into a three-dimensional image, all right? In this particular one, this is a real patient, and you can see that the anatomy is digitally enhanced. It's drawn in, all right? But this is from a real patient. I can take this, I can subtract structures, I can add structures, I can rotate this with the touch of a finger. Anybody here have an iPad? Yes? me see. Okay. This operates like a giant iPad. With my finger, I can roll this in any direction I want. Look from above. I can slice it and rotate it, all right? And this image is just the digitally enhanced one, okay? I can also look at patients like this. This is a real patient, okay? This is one of our patients. So I can look at it in this way, but I can also look at it in what we call the slice mode. These slice modes show me the three different planes, right? The sagittal, coronal, and cross-section, right? I can scroll through the body, okay? These are what the CT scans have developed, okay? Now, this table is loaded with the digitally enhanced model I just showed you, male and female. It's also loaded with about 100 real cases of patients. It comes with the table. But on top of that, I can take CT scans from any patient in our own radiology department, from our hospital, and load it onto this table. So if a clinician has a patient who's had a CT scan, he can bring it to the table and load it, and he can see their anatomy like this. Now imagine that you are a surgeon and you have a very difficult case in front of you. Your patient has had a CT scan and you find that tumor. So you put their patient's CT scan on here and you see the tumor. Now you can roll that image. You can cut away everything else, just look at the tumor. You can see the blood vessels that are supplying that tumor. Now you plan how you're going to do the surgery. Your patient goes to surgery, you do the case. Now they have a CT scan afterwards, and you put it on the table, and you see how successful your surgery was or was not, okay? So clinicians are loving this table. But let me go back just how to teach with this, all right? Because we are starting to teach with this. So I'm going to show you, I really need the lights down. If we could just turn them down. So this is a video. It's just a 3-minute video, all right? And we made this really to demonstrate to some of the other faculty who are not clinicians what this table is capable of, all right? And there is audio with this, all right? Oh, that's not right, sorry. Let me see if I can get this. Oh, it is going, but there's no audio. Hold on. So what I'm demonstrating is that I can rotate this, all right? I can add layers of tissue and subtract them. See, those are the jugular veins there. So now I can convert the same image to an X-ray, all right? You can see that cervical vertebrae, fairly normal here, okay? This is actually the patient is a young boy, all right? Now I'm looking at the same patient, just a different view, right? You can see the larynx right there that I'm circling, all right? Yeah, the larynx looks normal, right? You can rotate it and you can see the trachea. I can take off the bones and now just look at that air interface, the tissues. Normal larynx, okay? But this is a case that the anesthesiologist said could not get access to the airway. They couldn't intubate this child, okay? So why not? seems to have a normal airway. But if we look at it in a little bit different way, now you see that, yep, airways there. Normal, but look at that mass, that dark mass. This child has an abscess. It's a retropharyngeal abscess. And that's why it's pushing on the airway so the anesthesiologist cannot intubate, okay? Now, if we compare this to another case, also a patient who had a difficult airway, could not be intubated, completely different. This is an adult, and you see how the cervical vertebrae are curved outward. This person is gasping for breath. They've got their neck stuck way out like that, okay? But the vertebrae look normal. If we look at the X-ray here, yes, the vertebrae look normal. They're just, it's stretched way out. But now, let's look at it in this view, all right? Look at the larynx here. Totally different picture, all right? It's swollen, right? Those aryepiglottic folds of the larynx are greatly swollen. And when you look at the trachea, you see how it's narrowed because of that. Okay? So completely different pathology, yet for the anesthesiologist, the problem is the same. They can't get a good airway, all right? So what's nice about this, we can compare cases, we can look at pathology, we can look at the relationships of structures, okay, from one case to another. So this is one of the ways we're going to bring anatomy and clinical medicine together, all right? Another thing that, thank you. Yeah, we could turn lights up if you want. Another thing that I can do with this is because I can put on our own cases, I can put this on there. I asked one of the radiologists to get me a case of a child, okay? And he gave me this case of a child who had an abnormality, all right? This child had what we call a vascular ring, a double aortic arch. Does anybody know what that means? Okay, so where's the arch of the aorta? On the right or the left? Yeah? How many say it's on the right? How many say it's on the left? Left, yes, well, thank you. Somebody knows. So the aortic arch, you only have one, and it's on the left side. But during development, you have one on the right and one on the left. And the one on the right goes away, okay? It's just part of development, normal. This child, that didn't happen. They kept both of them, all right? So this is one of the things that, you know, we teach embryology, but students don't like embryology. It's just, it's not enough of the course. We only teach 10 hours of embryology in our course. It's not enough for students to really get excited about it because they don't get any kind of real substance, you know? And it's difficult trying to get them to study it because we're just using sort of illustrations. Well, with this is a case, you can see here, you see how you see the sternum here? All different bones? It's because this child is 6 months old. All right? So the sternum has not all fused together yet. But this is an image on the anatomage table. And what I can do is clip away structures that allow me to look at inner structures. So I've clipped, see, I've turned it. I've clipped away the ribs, and now I can see the whole aorta and the arch. And then I clipped away the vertebrae and turned it. And now I see the entire aorta, and you see the two arches. And then I can tilt it, and I see that ring of vessels at the top. Can you see this? Right? See right there? Right? What goes through that ring? The esophagus and the trachea. And so in this same child, I can now look at this image, not with the lights on, I can't, but I can look and see that the trachea is very narrowed because of that vascular ring, right? So here we can teach embryology and pediatric anatomy in a much more dynamic way. All right? So this table has really, we just have been starting to work with it. I got to play with it for about 6 months all by myself, just learn how to do it, and it is, believe me, it's like you sitting at home with your video games. I've been just having a great time with it. So, but one of the things we're going to do is take this technology and combine it with other things in the simulation center, because I can only get so many people around the table. So we'll do some sessions with the anatomage table. We'll do some sessions with standardized patients and ultrasounding them, students doing it. And then we'll set students up in one of the scenario rooms, and we can look at the same anatomy in all 3 of these locations. But students get different experiences, and they can sort of integrate that whole, all of those things. So what this has allowed us to do, like I said before, I think simulation is really where education is going. The longer you're in it, the longer you're in any kind of healthcare field, the more you're going to see it, the more exciting it's going to be. You know that yourselves. You all have, how many people just bought the new iPhone? Comes out, every 2 years you get a new iPhone, right? Because the technology changes. That's going to continue to happen in medicine. So, as far as anatomists, our job really is to teach students basic anatomy still, to help them integrate it with other disciplines, and then to show them how it applies to medicine. But as they go from first through their 4th year or so, learning tends to be more self-directed, less dependent on a teacher. And so our jobs at that point become, how do we create the environment and the opportunities where students really can learn for themselves, okay? All right, I'm going to stop there. I think we've had, a little over time. All right. Good. I'm fine. Thank you. Yeah, I'm good.
Hello. Ok. Professor Ivo, nós vamos abrir para 2 perguntas. 2 perguntas, ok? 2 perguntas para que vocês possam fazer a intervenção juntamente à doutora Anne. Por favor, nós vamos levar até vocês o microfone. A professora vai colocar a tradução. Nosso tradutor vai intervir, ok? Eu vou até vocês. Fala o teu nome, o teu curso e a tua pergunta bem objetiva, ok?
Hi, Anne. Hi. Nice to meet you. I'm Luana. I'm a physiotherapy trainer. I would like to know, in your opinion, what do you think the principal difference about learning anatomy actually in the future? Because at the end your presentation you would talking about that.
Mm-hmm.
So less the facility, because yes, the technology possibilities some things, facilities, but concrete. What's different in future? Learning the future anatomy.
Well, I think I can probably answer that as well as you might be able to. Because I think the answer is technology. I think it's going to change things so dramatically, and I think all of you have experienced technology in the same way I have. So it's going to change things a lot. But I think, like I said earlier, anatomy, I love anatomy. I can read anatomy and study anatomy just because I love it. But that is really not why you study it. It's not why we teach it. It's a tool for you. It's like a hammer, right? I can teach you what it looks like and what the names are, all the parts, but if I don't teach you how to use it, it is useless to you, right? So we teach it for you. We teach it so you can use that. And I think you're going to be using it differently, because I think medicine is going to be using anatomy differently. Think about the changes in medicine. Everything, surgery, everything involved a big incision, you opened it up, right? They don't do that. They hardly ever do that anymore, okay? They make little tiny incisions and put cameras in, right? So medicine changes. So the way we teach anatomy is going to change, all right? And I think you can imagine as many things as I do about that. We are going to probably get away from heavy dissection courses, because I think medicine is getting away from more and more of that heavy anatomy. Everything is virtual. Now, I'm not saying that we should get away from dissection, but I think that's eventually going to be. I think medicine is going to be virtual, and so I think teaching anatomy is going to be more virtual.
Yeah, the clinical relevance about virtual medical, but about the technology, there is a lot of information, and not only true information. So you can be confused about another information. For example, you show about wrong information of clinical patients. Is some common in your life when you search information about the patients, but is a false information. There are another hand about the technology.
I'll tell you another thing that I think is going to change the way we look at anatomy and medicine is that I'm sure it's true here in Brazil as it is in North America. Populations are getting older, much older. People are living much older, and anatomy of an elderly patient is quite different. So I think we're going to have to teach it differently. I think we're going to have to include much more of what is normal anatomy in an elderly person. So medicine is going to change in that way, but I think the way we teach is going to have to change in that way.
Okay, thank you very
You're
much.
welcome.
Quem mais levantou a mão aqui para fazer a pergunta? De um aluno? Você?
Boa tarde, meu nome é Douglas, faço enfermagem. Uma coisa que a senhora se datou muito foi no fato da senhora utilizar a tecnologia no ensino da anatomia. E a mesa que a senhora apresentou para a gente, ao qual a senhora consegue escanear o corpo e torná-lo em 3D para que a gente possa assim, dissecá-lo e ver especificamente determinadas partes do corpo humano. E não só minha dúvida, assim, mas uma curiosidade até das minhas colegas, é que se a senhora tem algum projeto de expandir essa tecnologia para o Brasil ou para as universidades aqui.
Okay. All right, so I apologize if you got the idea that I invented this table. I did not, okay? This table is produced by a company in California. My simulation center purchased it a year ago. So I am not a technician at all, okay? I can use my laptop and I can use the table, but I can't invent things like that. So no, I don't. But I will tell you this. I saw that table in, I think, 2009, when I was at a national conference in the United States. I was very excited about it, just like you are, and I went back to my university and I said, you need to buy that. I don't know why they listened to me, but they did, they bought it. But it's only been in the last 2 years that medical schools have started buying this. They're only in the entire world, there are only 300 of these tables, okay? There are almost 100 of them in South America, okay? But this past summer, when I was at a national conference again, there is a new company that has put out a similar but slightly different table. So yes, there certainly are projects to expand on this table. It's the original, and I think the software and the innovations that this company has displayed with this, I think we're going to see more and more of that. Yes, for sure. There's going to be lots of competition to do it better and better. So I think you should talk to your dean and tell him to get one.
Ok? Thank you, teacher. Vamos fazer aqui, então, a gente vai fazer uma visita ainda ao CEMED, a um dos nossos centros de... Não? Ok? Não dá tempo? Ok. Vamos
fazer o sorteio do livro.
Oh!
Pessoal, eu gostaria então, meu nome é Andréia, o professor Oscar apresentou no início. Eu sou representante do GEM, Grupo Editorial Nacional. O GEM é uma empresa, fornecedora de conteúdos e soluções na área de educação. E nós temos uma parceria de alguns anos com a Anhanguera, agora a Anhanguera Croton. Nós vamos fazer agora o sorteio de 2 exemplares do Atlas de Anatomia, da professora Anne Gilroy. Como ela falou, o Atlas é uma das ferramentas importantes para o estudo da anatomia. Vocês viram que tem a tecnologia, mas também tem a utilização do Atlas no aprendizado da anatomia. E a Anhanguera utiliza o Atlas de Anatomia em todos os cursos da área da saúde, o que nos deixa muito felizes e possibilitou essa oportunidade de trazermos a autora para conversar um pouquinho com vocês. Então, eu agradeço imensamente, é uma oportunidade muito feliz para todos nós de estarmos aprendendo e estarmos em contato com a professora. Obrigada.
Okay, what do I do with the numbers? Oh, you have the numbers.
Ok. Professora Luciana, por favor, aqui. Quem mais está aqui? Por favor, professor Ivo, Andréa, professora Raquel. Então, vamos lá. Com bastante calma, nós vamos fazer o sorteio dos 2 livros, ok? Lembrando que ele tem a versão PLT, professor Ivo, por favor. Versão PLT, ok? Para poder fazer aquisição na nossa biblioteca, e também a versão aqui que a doutora Anne trouxe aqui para vocês. Lembrando que serão disponibilizados certificados nas coordenações dos senhores, conforme vocês colocaram o nome, o curso e e-mail, ok? E também, ao saírem com bastante calma, para poder devolver o aparelho e pegar o documento de vocês. E os contemplados para receber o livro, autografado pela doutora Anne, é o número 8. O número 8 está aqui, levanta a mão para poder identificá-lo. Número 8. Está aqui? Não? Por favor, vamos lá então. Muito bem. Ok. Por favor, pode subir aqui para receber. E também o número 27. 27, não está? Se está, levanta a mão, por favor. Aí. Muito bem, um aluno e uma aluna. Pessoal, vou pedir uma salva de palmas para a doutora Anne, que veio aqui nessa tarde trazer para a gente conhecimento especial. Muito obrigado, pessoal da Global Traduções. Muito obrigado a você, Cláudio, Felipe. E tenham um bom proveito, uma boa tarde a todos. Obrigado.
Oops, sorry. Jacqueline.
Ele garante que ele. Vem cá, vem cá, espera. Aí, tira a foto das duas.
Congratulations.
Tira a foto. Vai você. Vai você.
Oh, yes. Thank you.
This book for
Hers? Okay. Okay.
Aí o teu?
Yes. Melina. Melina. Yes. Okay. Whoa. I'm kind of blind with all the. Melina. Melina. Mhm. Oh, Lina. Sorry.
já devolvi para a biblioteca.
Tem que escrever o nome dela aqui?
Sim.
Da Priscila? É. Aham. Calma aí, ó. Ela tirando a foto, deixa ela tirar a foto.
Oops, somebody else?
This paper was sent to Professor Priscilla. Just a...
You just want my signature?
Yes.
Okay. You're not going to sell this, are you?
The last one.
That's okay.
Daniele.
Daniele.
But the other book?
This is in my book?
Another one.
Yes, thank you.
Mas ela vai assinar.
Then who's this?
The other one.
Yes, this is in my book. No, I don't. Okay.
Fantastic. This
Really?
label is fantastic.
Isn't it amazing? That's why I saved it for the last place.
Picture, stand up, please.
Oh, yes.